Let's now talk about drug metabolism. Not every drug is metabolized, but when drugs are metabolized, they're generally converted to something that is more water-soluble, and often it may be converted to something less active or inactive. On rare occasions, it may be actually metabolized to something that is either active or even toxic. So the outcome of that chemical reaction, that metabolism, really varies based on the drug and the patient's metabolic processes involved. But the general reason why drugs are metabolized is to convert a drug that is fat-soluble into something that's more water-soluble, so ultimately the liver can get rid of it. Classically, we think of drug metabolism as primarily happening in the liver, but truth be told, it happens in lots of places. It happens in the GI tract, it happens in the kidney even, happens in the bloodstream, depending on the nature of the chemical reactions that can happen. And there's a wide degree of variation in drug metabolism from person to person, and not every drug is metabolized. Some drugs enter the body and exit the body as the original same drug we administered. So drug metabolism, we think of liver as the primary site, but as we alluded to, other places as well. And generally, some orally administered drugs go through portal circulation and actually might get metabolized before they enter general circulation. The process of drug metabolism, if it happens, if a drug gets metabolized, and typically the drugs that are going to be metabolized are the fat-soluble drugs. The water-soluble drugs, interestingly, don't usually go through a lot of drug metabolism because they end up to be water-soluble enough to stay in the urine and excreted by the urine. But the fat-soluble drugs need to be a little bit more water-soluble so the kidney can get rid of them. Which drugs are likely going to be the most likely drugs you're going to see that are fat-soluble and a victim of metabolism are going to be the drugs we use in neurology and psychiatry. Why is that? Because those fat-soluble drugs needed to be fat-soluble in the first place so that they could cross the blood-brain barrier. So we'll talk more about that. The types of metabolic processes that happen, there are basically two categories we think of. One are phase 1 reactions. Phase 1 reactions are oxidation reduction reactions. And these involve enzymes. Usually what we'll look at the enzymes involved are the cytochrome P450 enzymes that have a strong genetic influence in who has those enzymes and how much of those enzymes they have available. Those oxidation reduction reactions involving those cytochrome P450 enzymes also are associated with many, many drug interactions. And so when we talk a bit about drug interactions, one of the major types of drug interactions we think about are where one drug affects the metabolism of a second drug, and it almost always involves, in those cases, one of these cytochrome P450 enzymes involved. And some of these drug interactions can be things that you don't think about. The classic one that we think of is a drug-food interaction that can happen where a food interferes with drug metabolism. That includes both grapefruit juice for some things, so you might have heard that some patients can't take grapefruit juice while they're on a certain medicine, or even charcoal foods, charcoal burned foods can affect the metabolism of some drugs like theophylline. Most drugs that are metabolized go through one of these oxidation reduction reactions, but some drugs go through a different type or an additional type of reaction called a conjugation. These don't involve these same enzyme systems. They're simpler types of metabolic processes, and all that basically happens is that the reaction involves getting something more water-soluble linked on to the parent compound. That could be a sugar or a sulfite or something like that. And those are called classically conjugation reactions. So the phase 1 reactions, here's another sort of graphic that depicts it. Phase 1 reactions are a degradation process. They mainly involve microsomal enzymes like the cytochrome P450 enzymes, whereas phase 2 are synthetic reactions. There's a conjugate of a glucuronic sulfate or something like that. And their metabolites in both cases are generally more water soluble, but the phase 1 reactions, the metabolites may or may not be water soluble. They may be active or inactive. Almost always the phase 2 reactions are inactive and water soluble. So these phase 1 reactions involve these enzyme systems called the cytochrome P450 enzymes. And the cytochrome P450 enzymes are a group of subtypes of enzymes. There are at least 30 identified, and they fall into families with these sort of letter and number names. Cytochrome P450, 1A2, 2C9, 2C19, 2D6, 2E1. Probably the most common is cytochrome P450, 3A4. What happens typically is that a drug, let's say in light blue here, enters via the gut lumen through the enterocyte, through the portal circulation, and may end up in systemic circulation, not metabolized at all, even though these enzymes were involved either in the enterocyte or in the liver. But sometimes the drug, as it goes through portal circulation, is actually metabolized, and what ends up is a portion of that drug in circulation isn't the original parent compound, it's the metabolite, which is the end product of this metabolic process, and that metabolite may or may not have pharmacologic activity. So if a drug had a high degree of metabolism before it ever entered systemic circulation, you'd expect then that the bioavailability of that orally administered drug would be lower because only a portion of the parent compound actually got into circulation. And if that was a very high degree of metabolism before ever reaching systemic circulation, then that would be considered a drug that has a high first pass effect, meaning on first pass through the liver, you had a drug that was metabolized to a greater extent. Sometimes that metabolic process actually happens before it even gets to portal circulation. That metabolism may happen actually in the enterocyte in the gut, so some of those enzymes are seen there as well. The nomenclature of these isoenzymes are very specific. The first number of the nomenclature is the family, and any enzymes within this family have about 40% of their amino acid sequences identical. In the subfamily, the second digit or number, letter in this case, if all the 3A's, for example, have 55% of their amino acid sequence identical, and all the 3A4 enzymes have 97% of their amino acid sequences identical. So what that basically means is that there are many, many subsets of these enzymes. How many you have, the different types are all genetically influenced, but these enzymes might be very specific for the drugs they metabolize. So if I have a drug that's metabolized by cytochrome P450 3A4, then depending on how much 3A4 I have, I may metabolize more or less of it, which ultimately means that how much drug I have available that's not metabolized is going to be influenced by how much enzyme I have and how much drug is there. You could also have that as the basis for an interaction, meaning that I have X amount of cytochrome P450 3A4 to metabolize my first drug, but lo and behold, I just added a second drug that also metabolizes that second drug. Those two drugs compete for the limited amount of 3A4 that's available, and guess what? The blood level or tissue level of one of those two drugs might go up or down depending on how competitive that reaction is for those limited enzymes. And hence, that's the basis of many drug interaction that we see in practice. The isoenzymes that we commonly see used are involved in the common drugs we use in practice. Depends on, they vary, but for most of the common drugs that are metabolized, and remember not every drug is, but maybe for a half or 2/3 of the drugs that we use in clinical practice are metabolized mostly by these enzymes. The most common one is 3A4. About half the drugs we use in clinical practice, if they're metabolized, are metabolized by cytochrome P453A4. We also have 2D6 and 2C, particularly 2C9 are other common enzymes involved in drug metabolism. When you open up a drug reference or a drug monograph, when you look at the drug you've got, if the drug's metabolized, usually in that reference that you have, it'll tell you that yes, it's metabolized, and then it will also tell you, if it is, which enzymatic process, if it's involved in one of these phase 1 reactions, which enzymes are involved. And if you see certain enzymes involved, you will probably also begin to recognize that that may also indicate which drugs are going to interact with this drug, because those other drugs are somehow influenced in one way or another by that very same isoenzyme group. The phase 2 reactions typically link up a sugar. They render the drugs less pharmacologically active and make them much more water soluble. They're simpler reactions and they happen pretty commonly as well as phase 1. And keep in mind that a drug may go through multiple different metabolic processes. Some drugs have 2 or 3 or 4 different processes or more involving different enzymes and different ways of metabolism. And what you may end up with is many metabolites, some of which may or may not be pharmacologically active. So just recognize that these processes vary by drug and by the extent of metabolism. We've already alluded to this concept of first pass, which indicates a significant amount of the drug is metabolized on first pass of circulation through the liver before it ever reaches systemic circulation. There are drugs that have a high first pass effect, meaning that I might give 100 milligrams of a beta blocker like propranolol or metoprolol, and yet only maybe 10% of that drug reaches systemic circulation that I've given orally, and 90% of the drug is metabolized to something inactive before it ever gets to circulation. So let's use an example that if you work in cardiology, you'd be aware of, is a drug called metoprolol. Metoprolol isn't one of these beta blockers, cardioselective beta blocker. And if someone is having a heart attack or a chest pain, the protocol in the emergency department is to give 5 milligrams of metoprolol every 5 minutes for a total of 3 doses, or until someone's heart rate goes down. The reason we do that, among other things, is to preserve cardiac, to reduce the oxygen demand when there's a problem with oxygen supply. Well, the dose I give IV is 5 milligrams, but if you opened up your drug reference, you might find that the dose we give orally is 50 milligrams. You definitely would not want to give 50 milligrams of metoprolol IV, but you would, if you had to give it orally, you may want to give 50 milligrams of metoprolol orally. Why 50 oral and 5 IV? You give 50 oral, 45 of that 50 on average is metabolized to something inert on absorption in the next 2 hours before it ever reaches systemic circulation, and only 5 milligrams actually reaches systemic circulation. And so by default, since 90% of the drug is metabolized before it ever reaches circulation, the beta blockers, particularly metoprolol, propranolol, are drugs that are considered to have a very high first pass effect. Another very common drug we use in practice that has a high first pass effect is morphine. If I give morphine IV, I might give a dose of 4 milligrams of morphine IV. The oral dose of morphine, of 4 milligrams of oral morphine, doesn't do very much. In fact, for oral morphine, I typically am going to have to give 3 to 6 times that much orally, because, and so I'm going to give probably a dose something like 15 milligrams of oral morphine to be equivalent to 2 to 4 milligrams of IV morphine, because morphine has a high first pass effect. Here's a graphic that kind of describes this. We give the drug, it's swallowed, it gets in the digestive system, gets to portal circulation, to the liver, and then ultimately to the rest of the body. And if that metabolism happens to a great extent before it reaches systemic circulation, by default, you'd expect that being a drug with a high first pass effect. Keep in mind that there's a lot of variation in patients' ability to metabolize drugs. It varies. You see drug metabolism happening at different rates in different people. Could be a function of liver or kidney disease, cardiovascular function, immaturity with infants. But probably the greatest reason for this variation in drug metabolism are twofold. One is genetic. The genetic predisposition for metabolic processes is dramatic, and so some patients will have a greater or a lesser ability to metabolize certain drugs. And secondly, are concurrent drugs that interact with each other. And so this variation is an important consideration. If you open up a reference and look at the standard dosing we give for a patient, you have to apply that to your patient and whatever you might know about that patient. It's likely that in your career, and maybe even in the next half a decade to a decade, we'll use pharmacogenetics, genetic DNA information, to help predict these type of enzymatic responses and doses we should customize to a patient. But in clinical practice, as of this moment, it is not commonly done because we don't quite have the level of sophistication and information to make it practical to get that DNA information and accurately predict what a dose of a drug would be based on someone's genetic predisposition. But expect that, and actually we've kind of expected it for the last decade, but it hasn't really happened yet. Expect that likely with more sophistication in computer enhancements that we use in prescribing, that we might be able to get to that level of customization and drug dosing better than we've historically been able to do. So as kind of a review here, let's look at a drug that goes through this process. Here's an example of a drug that doesn't get metabolized at all. So it might be a fairly water-soluble drug or drug that doesn't undergo metabolism. So the very compound that we gave that was absorbed got through the portal circulation and into systemic circulation, ultimately excreted in the kidney as the very compound we gave. Nothing changed. So an example of this might be amoxicillin or ampicillin antibiotic. And what used to make amoxicillin or ampicillin a reasonably good choice when the spectrum of activity was a bit better in bygone days for urinary tract infections was that ampicillin or amoxicillin actually gets good high levels in the bladder, in the urine. The reason we don't use it as much anymore for urinary tract infections is the most common pathogen for urinary tract infections is E. coli or Escherichia coli. And over the last 2 decades or so, we've used antibiotics so much that we've lost a lot of the sensitivity, or the antibiotics are less effective for E. coli, the most common type of community-acquired urinary tract infection. But here's an example of a drug that's absorbed and passes through the body, eliminated, unmetabolized. Sometimes a drug is absorbed and then undergoes metabolism either on first pass or later on after it's circulating in the body and kind of repasses through anaerobic hepatic circulation or gets metabolized someplace other than the liver. And those circumstances we think of are the drug gets into systemic circulation as a metabolite. That metabolite may or may not be pharmacologically active. That metabolite may bind to receptors, maybe the same receptors as the original drug we gave, maybe different receptors. But what gets excreted in the urine is that metabolite, that chemically converted drug. And for fat-soluble drugs, in fact, some of it has to eventually get metabolized enough to make it water-soluble enough to get out of the body.